thank you all for coming, and thank you, John and Sean and Stephanie, for arranging this. I could say this is paying for single payer take 5, take 3. I don't know. Some of you have come to these before. Some of you have come to them several times before. So there'll be a lot of repetition because the basic issues haven't changed. The numbers keep going up with time and inflation, and the continued deterioration of the existing the existing private health insurance, private marketized healthcare system. But that said, I'm always tweaking things, and I think every go round, every iteration, the numbers get a little better, and there's more to say because other things have gotten worse. Okay, so here's the getting worse, and this graph I haven't updated since the COVID epidemic, but this shows in the, if you take away one thing, one measure of how bad our healthcare system is, both in delivering healthcare and in costing too much money, take this graph. On the horizontal axis, you have spending, and each line is a country with spending in different years. So if you go back to 1970, all the way down here, we were spending a little bit more than everybody else. Since then, our spending has increased faster than any other countries. Now, if we were getting more and better healthcare, you could say, okay, we're spending money, we're getting better healthcare. Who's to criticize if we want to buy more healthcare or buy more life expectancy? But no, our life expectancy has fallen behind every other country. These are all members of the Organization of Economic Cooperation and Development. So these are affluent countries like us. And our life expectancy has fallen behind them, and fallen behind by ever more. And we're not only talking about rich countries. We're not just talking about Switzerland or Norway or Sweden. No, we're talking about Chile, Greece, countries that you think we should be doing better than. But as was pointed out in an article that I read a while ago, if you get to, if you're a Black man in American inner cities, your life expectancy is worse than if you were in Lagos, Nigeria, or some other relatively poor African countries. Your life expectancy in the United States is not much better than in India, where, as I mentioned, my younger daughter has been hanging out. On the other hand, you'll be spending a lot more. Now, why is 1970 a good year to start? That's because that's when we began to, in a serious way, privatize what our healthcare system. Of course, it was privatized before. We had private health insurance. But in the 60s, we established Medicare, Medicaid, and there were many people, including Richard Nixon, who were proposing major increases in health insurance to establish a national health insurance system. What Nixon proposed was a lot less than what Ted Kennedy wanted or what we wanted, but 1971 was when Congress first established subsidies for HMOs, private health maintenance organizations. This started as a reasonable idea because Kaiser Permanente back then was a very good healthcare system. But obviously, things got worse from there. At the same time, 1971 was also when Canada fully nationalized its Medicare system. I swear they call it Medicare just to make fun of us because their Medicare system is actually universal coverage. Well, our Medicare system, well, as you know, seem to have lost something there. Okay, moving on. Now, we arguably have the best healthcare system of any state in the United States. Certainly we're in the top 5. Hawaii, maybe. Hawaii is better, almost certainly. And, a few other states, Minnesota, Oregon, have very good healthcare systems. But we have as close to universal coverage as any large state. But even in Massachusetts, there are parts of the Commonwealth where people do not go to the doctor because they can't afford it, and they die at higher rates than in other counties. Counties where the proportion of people who report they cannot afford to see a doctor, where that proportion is higher, have significantly higher mortality rates. So these are age-adjusted mortality rates. So it's not just that the counties with old people. And these are counties where somewhat fewer people have health insurance. But the major factor is not whether people have health insurance, it's whether their health insurance actually allows them to go to the doctor, actually provides meaningful coverage. If you have a $2,000 deductible as a standard for private health insurance these days, or a $3,000 deductible, or a $4,000 deductible as not uncommon, then you really can't afford to go to the doctor, except if you know that you have a catastrophic condition. And of course, by the time you know it's a catastrophic condition, it may be too late. Certainly, and this is the economist in me talking, certainly if you go to the doctor only when conditions have gotten really bad, it's going to cost a lot more to fix you, which contributes to this line stretching out towards the horizon. Okay, now, a former co-teacher of mine, who you may have heard of, Ezekiel Emanuel, his brother was mayor of Chicago, and they made a TV show about his other brother called Entourage. He was health advisor to to Barack Obama. Very different. Zeke's not a bad guy. Well, I don't know, but he's like, oh, you can't use life expectancy. Those are numbers that are due to all sorts of things. Well, okay. You take out homicides, take out gun deaths, take out suicides, which may reflect poor health care, take out opioid addictions, and you're saying, okay, let's lower the US death rate by 200,000. And then compare our deaths with the number of deaths that you would expect in other countries, given their death rates. We still currently we're running before COVID, we were running at 400 to 500,000 excess deaths compared to the average for other countries standardizing on our age distribution. Take out the 200,000 or so deaths that I mentioned, and don't add back in, by the way, we are relatively safe drivers compared to other countries, one of the biggest causes of death. But okay, forget about that. We're still 250, about 10% more deaths than we should have if we were like other countries. And that's apart from deaths by violence, deaths by suicide, deaths by overdoses. Then look what happened with COVID. And I actually wrote a paper on this. With other people who paid us. Look what happened with COVID, 2020. We had 270,000 additional excess deaths because our healthcare system failed during COVID. And then the following year, 2021, 400,000 excess deaths. Additional excess deaths because we had more deaths than other countries did with COVID. What accounts for these? Read our articles. Lack of health insurance. Lack of health insurance explains most of the excess deaths that we had because of COVID. Now, this is not only people who didn't have health insurance, but places where people do not have health insurance, other people usually have worse health insurance. So you put those two together, and as much as 30% of our deaths from COVID have been because of the health insurance system. Okay, this isn't my article, by the way. There's a link down here. Okay, so what can we do to fix it? This is one of those things where, even Zeke Emanuel, well, maybe I shouldn't say that. I'm not sure it's true, but many academics and health policy people who, if you ask them, what should we do about healthcare? And they'll go through, value-based care, this, that, whatever. And then you say, well, what about single payer? And they'll say, well, if we could do it all from the beginning, single payer would be the way to go, but it's too difficult to do now. Well, I think at least the first part of that is settled. If you go through the literature, and there have been a whole lot of these studies, and everybody finds that if we had a single payer system on a state level or a national level, it would be cheaper than the current system, even after you go to the expense of covering everybody and giving everybody access to healthcare by providing not just insurance, but good insurance. In our case, we're talking about good insurance without co-pays or deductibles. The way I do it, which pretty much the way everybody does it, you start with the current system. You consider how much would it cost to cover everybody? How much would it cost to give everybody access? No copay, no deductible. And then if we're going to have a single system, how much would it cost to raise Medicaid prices to the prices that we're paying everybody else? That's might seem like, just a bonus to the doctors, which it is, of course. But it's also provides access. You can have Medicaid. In Massachusetts, Mass Health is pretty good at this, but still, you can have Medicaid, but it doesn't mean you're going to be able to take it to a doctor who will actually treat you, because the rates are a lot lower than they get from Medicare or other places. Okay, so that gives you the expense. Then you think about the savings from the administration of the health insurance system. Instead of all the advertising and all the utilization review and all the negotiations that the insurance companies do, just give and the high pay to their CEOs, get rid of that. Just run administration on something like the Medicare system level. Save money on provider administration. Go into a doctor's office, you look around the corner and you find all the people who, what is their job? The job is to process paper for the insurance system. And then, let's get serious about negotiating drug prices and device prices. And oh boy, this is a tough one. Let's negotiate prices with Mass General Hospital and the other elite monopoly hospitals. It's not that they're elite. That's fine. I'm happy with that. I love Dana-Farber. But let's negotiate prices with monopoly hospitals that overcharge because they can get away with it. And some providers. And then this is a magic asterisk number, fraud. We know there's fraud in the system. It's very hard for private health insurers to eliminate fraud. A state system with subpoena powers, with police powers, could reduce it. Estimates run between 8 and 15% fraudulent billing. I'm assuming we'll get rid of 2 percentage points of total cost because by reducing fraudulent billing. That's nobody really knows. Fortunately, the whole system doesn't depend at all on that. Okay, source of revenue, we have current revenues that what we're already spending, the Medicaid system, Medicare, and as John signaled, we can talk about that. And the Veterans Administration, which we're not going to be touching, so that just flows in one way, out the other. And we're left with a certain amount of money, new taxes. We can call them something else. We can call them premiums. We can call them something more innocuous sounding, but at some point we're going to have to collect more money. Okay, here's what we start with. And I'm looking at 2025. I did this by blowing up what we were spending in 2019, adjusting for population changes, projected rate of growth in spending using estimates from the Commonwealth, not the Group Insurance Commission, the Commission on Health Insurance Costs, which are lower numbers of inflation than the feds have been predicting. And that gets you personal health care. That's spending on providers, what you spend to go to the doctor, not counting insurance administration. $110 billion in 2025. Then improved access. That's when we eliminate copays and deductibles. And when we provide coverage for everybody. $4.8 billion. Honestly, that may be a little low, it may be high. I assume very little hospital usage increase, because if you're going to the hospital, you're going to be going to the hospital. More increase in dental and vision. Otherwise, I used estimates of the impact of improving health insurance quality from the CMS, Center for Medicare and Medicaid Services. Raising Medicaid prices gets us up to another 4.9 billion. So that's total personal health care. Add to that insurance administration at the rate of current health insurance administration. The current actuarial value of health insurance plans, the Medicare loss ratio of health insurance plans, which is the proportion of premiums that get spent on health care, is a little less than 88%. So over 12% of your health insurance dollars, and this includes Medicaid, it includes Medicare, and it includes the group insurance commission for the Commonwealth. Over 12% is spent on administration by the health insurance companies. Private health insurers spend about 20% on in administration. Average CEO salaries are $10 million plus. Okay, that gives you the total system. The existing system, if we were covering everybody, would cost under $35 billion. Savings, hospital price adjustments would be $11 billion. Negotiating prices with hospitals, lowering them all to the Medicare rate. Now, mind you, Mass General gets a higher Medicare rate. I'm picking on Mass General, but they're the worst for this. They get a higher Medicare rate than any other hospital in the Commonwealth because they are an urban hospital, so they get a bump up, and they are a research and teaching hospital, so they get a bump up. And we would lower everybody to 10% above what they're getting now. 10% above what they're getting now from Medicare. Mass General actually has very low Medicare billing because they can make more money on private health insurance people. They steer Medicare billing to some of their satellite facilities, like Cooley Dickinson. Other hospitals get more Medicaid people and get more, more Medicare people and more free care. So those hospitals will do very well under the system. The big losers on that $11 billion, and we'll talk about it some more later, are the elite urban teaching hospitals. Okay, physician price adjustment, lowering physician prices by about $2 billion. those are elite physicians. You know, you get an explanation of benefits from your insurer. I mostly open them, you know, and stick them in a drawer. But occasionally you look at them and it's like, wow, they charged that? You know, drug and device pricing, $10 billion. Most of that is lower prices for prescription drugs. Prescription drugs in the United States have been going crazy, prescription drug prices. When I first started doing this stuff about 20 years ago, the estimate was that US prescription drugs were about 37% more expensive than prescription drugs in other countries. That was from McKinsey. Now, according to RAND, they're over 200% as expensive as in other countries. So we would lower those to world levels, or not to world levels, to half of what they are now, which is what the Veterans Administration pays. Now, the Veterans Administration is a good comparison here because it's about the same size as Massachusetts. Device pricing, my wife hurt her knee, so she got a brace recently. We got a bill from the brace company for $75. And I looked at that, I passed it to her, I said, hey, you know, that seems a little high. I mean, our deductible, da. Okay, so she called and she found out, yeah, they had already gotten the insurance money. The company was charging $700 for this piece of plastic with Velcro. $75 seemed like a perfectly reasonable price for this brace. $700? Okay, provide administration. This is the people in the offices. This does not include all the time wasted for doctors. About 20–25% of doctor time is what is spent on billing and insurance related issues. Insurance administration, that's getting rid of most of the insurance, getting rid of all their advertising, getting rid of all that stuff, and running a state system as efficiently as the Medicare system in Washington, getting rid of fraud. Total savings, $48 billion. Someone's going to lose money. There'll be winners, there'll be losers. Hospital networks will be big losers. They're going to have to lean up or lean down, become more lean. Some highly paid specialists will lose. Big pharma will be the big losers there. Poorly paid staff will be losing jobs. So our bill provides for retraining and unemployment insurance adjustments. You know, I might point out that the average, as of a couple of years ago, and I think it's probably worse now, the average person has an 8-month turnover in these jobs. They don't like the jobs very much. We're not hurting them very much by helping them get something better. Doctors and hospitals will win big on Medicaid price adjustment. And insurance administration, they'll be lose. Cheaters will lose on fraud, like the senior senator from Florida, whose company had a $500 million Medicare fraud fine. Rick Scott. Okay, here are the existing revenues. Again, I took 2019, I massaged it a little and blew it up to 2025. Medicare, there, to get that money, we're going to have to get the feds to agree to us establishing a Medicare Part C type program and then offer that to everybody. Now, everybody who joins that program, we will be paying their premium, their Medicare Part B premium. We'll be paying any Medicare Part D premiums. They will get a better insurance plan than any private company is offering. No copays, no deductibles, full range of services. So I think that virtually everybody will sign up, especially since facing competition like that, private insurers are going to exit the state, the Commonwealth. But we will need cooperation. The feds will have to agree to this. Now, the rules of Medicare are very clear. You can offer a Medicare Part C program so long as your coverage is as good as existing Medicare. So they would have no business turning us down. Okay. Medicare, Medicaid, that's a state program. We can do whatever we want, so long as we're not reducing coverage. And even there, the feds have been letting states reduce coverage. The VA, we're not touching. There are other revenue from state, from school, public health programs, et cetera. We'll be picking all that up, which will be great if we actually provide nurses in every school in the Commonwealth, which is to be sure, that's an expense I'm not counting. There'll still be some out of pocket because existing federal data includes spending on bandages at CVS, aspirin, et cetera. We're not going to pay for that stuff. People still have to do that themselves. There'll be more ACA subsidies because there are more people. Some of the people who are not covered, who do not have health insurance, actually could get an ACA subsidy if they signed up. And then Medicaid. Because we'll be paying higher prices, we'll get half of that money back from the feds. And there are people who are not covered by Medicare who are eligible. Okay, with all that, we're still going to need, how much did I say? Oh, we're still going to need like $20 billion more. We'll get, the current plan has $30.6 billion in revenue coming from payroll tax. There are exemptions for small employers, a tax on non-wage income. We get $30 billion. That gives us a $7.5 billion surplus. That's enough to cover, my mistakes. Now, to be sure, there is other money because, well, we'll get to this in a minute, but this is not counting the money that public employers are paying for health insurance for their workers over and above the 10% tax rate. Okay, we'll come to that in a minute. Okay, middle class gets a big tax cut. I am less, this is a progressive tax program because of the tax on non-wage income, which is mostly earned or mostly collected by the rich and super rich. But that said, even a program that was less progressive would still be progressive in impact, because the current system, we pay for health insurance with a lump sum tax, a private tax in effect. Because in Massachusetts, you're required to have health insurance. So this is a Commonwealth mandated private tax collected by a private insurance company as a lump sum. Everybody pays the same amount. The $25,000 or so that the cost of my health insurance is the same as the $25,000 that is the cost of the department secretary's health insurance, who earns half what I get. And that's the same $25,000 that is the cost of the janitor's health insurance, who earns a third or a quarter of what I get. It's just that $25,000, while it's really unpleasant for me, is burdensome for the secretary and crushing for the janitor. Yeah. So getting rid of that and putting in something, a premium that's related to income, is going to be really good for low-wage people, good for middle-income people. And, well, as you can see, millionaires are going to be shouldering the load, which is fine with me. They can afford it. Okay, the public will save money, and this is where we get, another area if we want to tap into it. In 2021, I estimate, and this is using Department of Revenue data, there are some issues with these data. For some towns and cities, numbers look a little weird. But I think the basic number results hold. Towns and cities are spending a lot on health insurance, and so is the Commonwealth. The reasons for this are a teeny bit complicated. A little bit that Commonwealth health insurance, the Group Insurance Commission, and what's offered by cities and towns tends to be somewhat better health insurance than is offered by private employers. Unions have negotiated, wherever they're involved, unions always negotiate for health insurance at the expense of wages. I may be wrong, but every union negotiation I've ever been involved with, that's been the case. One of my teachers in grad school, Richard Friedman, actually has a paper about this. That said, the larger factor is a hidden one. Public employers offer family coverage at a much better rate than private employers. Family coverage has almost disappeared from the private sector. If you have children and you work for a private employer, you're largely out of luck. So in many cases, who's covering these people? Who's covering the children? Around Amherst, you see, at least around Amherst, you have the answer, which is the spouse, one of the parents works for the Commonwealth, often at a low-wage job. But because they're there, they get family coverage. And then the whole family is shifted onto the public purse, public health insurance. So the public sector is providing a health insurance subsidy to private sector employers by covering the family members of private sector employees. We had guys fixing our roof a few years ago. Both of them were married to teachers, and they went into business together. They don't have health insurance in their construction job, and they're walking around on the roof, not safe. But their teacher wives have health insurance, and that's what's paying for their kids and themselves to have health insurance. That's a common phenomenon looking at the numbers. Okay, so cities and towns will save $1.8 billion. Maybe Amherst could fix the goddamn potholes in the roads. I would like that. The Commonwealth will save almost $1 billion itself by moving from the current system to the more efficient system and a system that would spread the burden of healthcare across the Commonwealth to all employers. We should have faster economic growth coming from this. By ending job lock, this is something that the Penn Wharton Center people who did the numbers for Elizabeth Warren's proposed healthcare plan in 2020. I was only very peripherally involved, so I'm not taking any responsibility or credit. It wasn't bad. It wasn't a bad plan, but the Penn Wharton people estimated that eliminating job lock would raise productivity growth by about 0.3% a year, which is quite good. What's interesting is that and also healthier people are more productive. They didn't factor that in. But what I did was I looked at productivity growth rate across the OECD as a function of various factors, including the quality of the health insurance measured by preventable years of lives lost. And the US is pretty bad on that. We have the worst numbers on preventable years of lives lost. If we move to the middle of the range, which is where I would expect us to go, at least the middle with this health insurance program, then Massachusetts would experience faster per capita growth. Income growth. Healthier people don't get sick as much, show up to work more often, feel better, are able to be more productive. And people can move to the job that fits them best. rather than being stuck at a particular job because, God damn it, I've got health insurance and my kids can go to the doctor that they are used to.
In the Midwest, 2 feet of snow.
Okay, so okay. There are some big losers. The biggest losers are the prescription drugs and the nursing and the durable medical products, like my wife's Grace company. Hospitals are losing. They're saving some money. They're getting more from Medicaid. And they're saving money on no longer paying for free care. That said, they're still going to be losing. And those losses will be concentrated in the urban elite hospitals. Mass General now owns over 20 hospitals throughout the Commonwealth. They own a lot of prescription practices. They use all these to funnel the highest paid patients to Boston while dispersing the Medicare and Medicaid cases in the periphery. This is all financial manipulation, and they use it to maintain high billing rates. They're not going to be able to do that. Physician clinical, they lose a little bit of money, but that's a wash, really. They gain on Medicaid, they lose on rates for a little bit. I mean, a few most highly paid, people may be losing a little bit of money, but they're going to have a much better lifestyle because they're not going to have to talk to some snot-nosed person in some insurance company in Omaha, Nebraska, and beg for approval for to do what they know needs to be done. So they're fine. Other professionals, and these include, vision and as psychological counselors, they'll gain higher Medicaid rates, and also because they'll be able to treat more people, especially vision. Majority of people don't have vision coverage. Dental services, they'll gain a lot because they'll really gain on the dental coverage. More people will be covered. More people will be getting dental care, which is a good thing. And they'll have higher rates on Medicaid. Home health care will gain. That's a very heavily Medicaid dependent field. Nursing home will gain, another Medicaid dependent field. And then other health is just, random various stuff, very small numbers of people anyway. Okay, the hospitals, to zero in on them because they are a major political problem. Everybody knows the health insurance company will hate this. Everybody knows the drug companies will hate this. And those are two big, powerful lobbies in Massachusetts. But the other one is the hospitals. And to quote Elizabeth Rosenthal in the New York Times last year before, everybody loves the hospitals. People donate money to the hospitals. Mass General is always sending me requests for money. It's like, you got to be kidding. The only thing worse is I get requests from Harvard for money. You got to be kidding me. I'm not going to give money to these institutions they've got plenty of money. But okay, mass hospitals now $40 billion. They'll gain coverage expansion. That's nice. They gain from Medicaid rates, and they gain from reduced charity and free care. They're giving, I'm projecting 2025, there'll be about $1.2 billion in free care, a bit more than they do now. But lowering prices is going to hit them. And again, it's going to be the elite hospitals with the biggest political clout. Hospitals in, Berkshire Medical, if they're still around, Cooley Dickinson, hospitals outside the elite circle will gain. But the elite hospitals, the must-have hospitals that are able to dictate prices to the insurance companies, they will be losing. They can't dictate prices to Medicare. Medicare is too big and too powerful. Okay, so Issues to think about going forward. I've been playing around with numbers on these things, and I'll get back to it at some point. Transition to leaner financing. That really depends on what on earth are they spending their money on. $4 million for the CEO at Mass General, and on down to others. That's a lot of money for individuals, but it doesn't really add up to all that much in Mass General. I know they've been buying a lot of real estate. They've been building a lot of buildings. We were in Dana-Farber recently. I have real mixed feelings. It's a beautiful building. Nice atrium, beautiful original art. You really feel good being there. But is this where we want to be spending our money? I don't know. I had a little dialogue with some friends about this, and but they definitely are spending a lot of money on amenities. Can Massachusetts stand up against drug and device companies? I think we can. I think we can because we're big enough, although, the VA does, and the VA is no bigger than us. We will have to establish a formulary and be prepared to walk away and say, well, we're not going to fund this drug. We're not going to pay for this drug. Also, California has been leading the way in starting to manufacture some drugs on its own. California is investing in producing insulin. They're not going to make it themselves, but they're contracting with another company. They're establishing the infrastructure. Many of the other highly expensive drugs have a generic counterpart, like insulin, which, by the way, you probably know this. The Canadian chemist who established artificial insulin, donated it to the world for $1, just like Jonas Salk. I believe yesterday or today was the anniversary of the first trials of the polio vaccine. Jonas Salk donated it to the world, made some beautiful statement about how nobody should profit from saving people's lives. Boy, they should put his words on, a billboard opposite Biogen and some of these other drug companies. Okay, federal Medicare funding. As I said, I would, I'm not a lawyer, but I have brothers who are lawyers, and I would be willing to fight on that hill. Okay, what the hell? Read my book. And this is, I am open to questions. Thank you all for your attention.
Yeah, thanks for people who have been putting questions into the chat. John's been compiling those, and we can take some of those. And see, there's also a hand up. John, do you want to go with some of the chat ones?
Yep. Thank you, Sean. Thank you, Jerry. Some of them, of course, gravitated to the hospital area. We should focus there a little bit. But one of the early things, Jerry, that you dwelled on was the loss of life due to the failure to have a single payer system. So there is a question, and we have Senator Jamie Eldridge, one of the bill lead sponsors here tonight. He asks, in terms of excess COVID deaths, does your report highlight how our poor public health infrastructure contributed to those deaths from the pandemic?
Now that you mention it, we did a lot. We were focused on the effect of health insurance coverage. And along the way, we factored out public health activities. So we could go back. That's a very good question. We could go back and should go back and look at the effects of these public health activities as a separate independent factor. Yeah, that's a very interesting point. And it's kind of, you focus on certain things and you lose track of other things. Yeah, I mean, we have those numbers. We just never looked at them. We have a whole vector. Travis Campbell, graduate student here, who did the actual econometric work, and that was in Oregon. He constructed a whole vector of public health activities, lockdowns, mask mandates, etc., as well as spending on public health in the county. This is a county level analysis. So he has the numbers. I am going to make a note and get back to Travis about that. Thank you.
Thank you. So a few questions regarding the hospitals, but before we get to some more general ones, can you do a basic explanation of global budgeting? Frank Farkas says, how does so-called global budgeting for hospitals work, and how does it compare to how hospitals are paid today?
Okay, global budgeting is something that the idea of global budgeting is we're going to treat the I've lost video. Do you people still, everyone still sees me?
Yes.
Okay. Okay. A global budgeting treats hospitals like the same way we treat the Amherst Fire Department. We give the fire department a budget, and we tell them, you fight all fires in this town. We can estimate, we demarcate, you fight all the fires within this area. And we can estimate if it's a large enough area, how many fires they're going to be. So we can kind of work out the budget, and the fire department hires the appropriate number of people. Occasionally, they'll have to come back for more money. Occasionally, they'll refund some money to the town. The same for the police department. The same for many public services. So the idea of this way, there's no bookkeeping about activities. I mean, of course, you do keep track of how many fires because that's useful information. But you're not billing individuals. You're not doing any of that. The idea of global budgeting is we would do hospitals in the same way. Hospitals would have a certain area that they're supposed to cover, and they treat everybody within that area. It would give the hospitals an incentive to treat people in the most efficient way. So if you have people who are developing, people who have diabetes, for example, or maybe people who are pre-diabetic, you identify those people before they have a problem, and you help them with diet, you help them with monitoring their sugar levels, etc. Because that's cheaper for the hospital than having them come down with some worse condition, losing their eyes or whatever. Hypertension. There are other areas where if we do more preventive care, people will be better off and will save money. That's the idea of global budgeting. It's done, something like that is done in some places. The state of Maryland has been experimenting with this. They are the last state to keep hospital price controls, which was abandoned in Massachusetts, I believe, under Bill Weld. Maryland kept that system. They moved to, it didn't seem to help much, but about 10 years ago, they moved away from it and they adopted a variant of global budgeting. And there is evidence they definitely have dramatically slowed healthcare hospital cost increases in Maryland. And there's evidence that they've been doing at least some of that controlling increases through expanded preventive care. And Maryland, it's not like Maryland has second-rate hospitals, whatever. I mean, they have Johns Hopkins, one of the world's top hospitals, comparable to Mass General. So we're talking about a serious place with the diversity of areas and comparable in size to Massachusetts. I've been a little hesitant myself. I know I got into big fights with some people about this. I've been hesitant about global budgeting because scoping out the areas strikes me as difficult in a small, compact area like Boston, where people, and in Massachusetts, people often go to hospitals across the area. If Dana-Farber has a global budget, would they treat me? Or would they say, oh, no, you have to go to your local hospital? I don't know enough about Maryland to know how they handle that problem because Johns Hopkins also is a major export industry. They treat people from all over the world, as does Mass General, and all over the state. So, I'm not sure about the details, but I certainly think it's something we need to look into. And it has worked in Maryland. I mean, the literature I've seen is universal that this is cost-effective and improving health. But it's a great question. Definitely something we need to look into more. Thank you.
Thank you, Jerry. And staying with the hospital question just a moment or two more, could you comment on critical access hospitals? Will they continue to get higher reimbursement? This is from Henry Rose.
Yeah. I mean, they would get critical access hospitals would benefit more from Medicaid adjustment. They also would benefit from, I don't know this for a fact, but I suspect that they do a lot more free care, and they would benefit from getting coverage there. So they would benefit on those. They would get their current Medicare rate plus 10%. So, there may be some lost revenue from the disproportionate hospital coverage, whatever the exact title is these days. But I think it would be more than made up for. They would be winners. As I said, the losses in the hospital sector would be concentrated in those with market power. The critical access hospitals do not have market power. Unfortunately, they should. They're doing God's work, but I'm afraid they don't. Yeah.
Well, we would add at Mass Care that the critical hospitals, that the distribution of hospital beds is going to be the power to distribute them equitably is going to be one of the functions of the new Massachusetts Healthcare Trust. And there will be a lot of power in that trust to make sure that the hospitals continue to exist where they're under threat.
That very important, because as we know, as these hospitals throughout the Commonwealth are being bought up by Mass General is funneling patients, the high-paid patients, to Boston, and then turning around and saying, "Oh, this hospital is losing money." So we should be cutting back, and the more you cut back on the regional hospitals, the more patients are funneled to Boston until you get to the point where Mass General can say, we don't need this hospital, it should be closed, it's a money loser. Putting the idea of which hospitals we're going to have, putting that on some marketplace thing that, we'll make this decision on the basis of who's making money rather than who's providing healthcare is, well, it will be great to change that. Thank you.
And Sandy Eaton, who's probably officially, I was going to say unofficially, the historian of the single payer movement in Massachusetts, has put a historical comment in the chat about hospital regulation or deregulation. And I think what we're saying here is that we agree with a point that Barbara Pearson made in the chat, that the single payer would give a level of rationality in resource allocation across the state. So back to an earlier question, Henry Rose also asked, what would you have us tell administrators at his two local hospitals, Pittsfield and Great Barrington? I guess, what would you have us have us tell them about their future under a single payer is what he's getting at.
Pittsfield and Great Barrington, I would think that they would, I haven't looked at the numbers there in particular, but I would think that they would do very well. They would benefit from the Medicaid price adjustment. They would benefit from eliminating free care because everybody will be covered. They will get a little boost in revenues because although it's not a big factor in hospitals, but people without good health insurance now will be more inclined to get care. That's a small factor. When it comes to hospitals, I think the end you end up going to the hospital. And then they're not going to have to be negotiating with all these different insurance companies. Their lives will be a lot simpler. They'll know how much money they're getting, whether we do it global budgeting or whether we do it fee for service, they'll be able to budget more easily and more rationally. And they're not going to have to be fighting with 8 different health insurers, plus the GIC, plus the different town plans, plus Mass Care. They're not going Mass Health. They're not going to have to be fighting with them all. They'll be able to just do their business of providing health care. They'll be saving a lot of money on staff because they're not going to have that office filled with bill keepers. And they're not going to have to be doing, what do they call it? Code upcoding. They're not going to. I was talked to a nurse a few years back at a hospital in Worcester who told me, they sent all of us out for a long weekend retreat to learn to upcode, raising the designation for patients so that you can get more money from the insurance company. Terrible for understanding our healthcare situation, and of course, a complete waste. And then, of course, the insurance companies fight upcoding, so everybody just spends more time with lawyers. So their lives will be a lot easier, and because they'll be able to focus on healthcare. And financially, they'll be fine. Plus, they're not going to have to worry about Mass General swooping in and buying them up, or Mass General getting their patients diverted to Boston because Mass General owns the primary care physicians in the area. Mass General partners a few years ago claimed that they lost $72,000 on every physician practice that they bought. To which you'd say, well, why did they buy them? Well, the reason is because what they lose at the physician level, they gain by steering patients to the more expensive care facilities. I say this as a Harvard alum. I love Mass General. It's just, as a financial institution, it's an atrocity.
Right. Well, you have to have something.
Okay, so moving right along. By the way, there's a few historical questions or factual questions in the chat that other people in the group might want to answer in the chat, such as the law. Have other hospitals been lost in Western Mass since 2014? But sticking to the economic analysis, we have a question regarding the premiums. Not the premiums, but we're calling it a tax for now, and the premiums we've called a private tax. How does the current split between employer and employee compare to the proposed split under our bill? The 2.5 and the 7.5 or 8.
That's about.
Yeah, go ahead.
That's about the same as the current split. Of course, there are employers that are different, but the average for private employers in the state and the average for public employers of the Commonwealth is about 75-25. So we're preserving that. There are still a handful of employers who pay 100%. And there's some who go down as low as 50%. There's some who will offer family coverage, but the employee has to pick up all the cost above what the employer was paying for the 75% of the individual coverage. So that
Yeah.
gets to a much lower number. But we're in the ballpark of what's currently being done.
And that was from Philip Katz, by the way. He also said that Jerry talked about having individuals pay 10%. So let's clear that up. What we're proposing in the bill is a 2.5% individual payroll tax, and the employer paying 7.5%, depending on size, 100 or more, will pay 8%. And that's the split we were just talking to, that relative split. However, the bill allows for the employer, and especially unionized employers, this will be on the bargaining table, to pay 100% of this 10% total tax or 10.5 total tax. So employees may pay from 0 to 2.5% through an agreement that will be protected by the state law and will also not be considered income to the employees. So I hope that answers Phil's question.
Yeah, it does. Thanks a lot.
Great. So then we have, sticking with the payroll tax questions, Joan at the Odyssey Bookshop says an additional 10% payroll tax on small business is difficult on our bottom line. It could wipe out our bottom line. It would be wonderful to have all employees to be covered by good insurance. Making the numbers work will be a real challenge. So what would you say to us?
That is absolutely an issue, because many, for those small employers who do provide health insurance, they will really benefit, because a small employer who's providing health insurance is paying at a much higher premium to the private health insurance company than a large employer. Rates go down with size. Economies of scale and bill processing and administration, and also reduced risk when you have a larger pool. So the small employers are in the worst position now, of the small employers who are paying for health insurance now. The problem comes up that many small employers do not provide health insurance. Now, part of me feels just angry and mean. You're a small employer, somebody is covering your people, either a public employer who's covering them through a private plan, who's covering them through a family plan, or Mass Health maybe, or maybe they just show up when sick and depend on free care. Whatever it is, somebody's paying, and as an employer, you should be paying, just like everybody else pays. We should all be chipping in. We shouldn't be subsidizing you. Probably there's a reason why I have never run for elective office, because I would come out saying things like that. And to be fair, knowing small employers who cover people like Nick Seaman at the Black Sheep in Amherst, where I recommend you get sandwiches, or others, it's not easy. And sometimes, especially when you're starting out, or if you're in a business that's an area where you're facing Amazon, et cetera, small employers could be providing a major public service. We probably should, just like I've been thinking about transition plans for the hospitals, we should be thinking about transition plans for employers, those who have not been providing health insurance. We should, we shouldn't have that mean attitude that I just expressed and say, well, okay, but we should give them time to adjust. I don't want to say we want to subsidize them, because why should we be subsidizing employers by size class? I definitely think we should subsidize bookstores, if that helps, but that's not something we can really do. I buy books, but I estimated a 2 years ago that I've added 4 linear feet of books every year since college. I had to measure for bookcases. And I don't think I've slowed down much. So, yeah,
Well, it's,
but it's a real issue, because if we're going to succeed politically, we need to address the legitimate concerns of small businesses.
well, we're at MassCare, we are launching a business committee for single payer, and there will be the ability of business people to weigh in on,
Mhm.
as you know, as most folks know, we reevaluate the tax structure and the budget of this trust fund every 2 years. One thing to clear up, though, is that when we were talking before about the split between employer and employees of the premium, it's the ratio that we were talking about, not the amount. Employer and employees will both pay about half what they're paying now under the current system. Is that about right?
Yeah, that's about right. And for small businesses that are providing health insurance, it will be an even bigger saving. The problem comes in for the small employers who are not providing health insurance, because virtually every large employer already does. And many small employers do. But small employer who is not providing health insurance now, they're going to suddenly be hit with a bill. I think it's fair that they should, as I said, I think it's fair that they should be paying, but we need to ease, at least we probably need to ease the transition, if for no other reason than politically.
Yeah, and of course, there'll be a lot of discussion of that in our committees at MassCare. So another question regarding the coverage and the reimbursement. Jean Anestis says, what about mental health, behavioral health care? Current providers are worried about lower reimbursements. Not all take Medicare patients because reimbursements are lower than from private insurance.
Yeah, if you have private insurance. Living in Amherst, we know several practitioners, and none of them take private insurance. I guess in other places they do. Most people do not have insurance coverage at all. So that would cover mental health. So even if you have even if you are taking private insurance, your clients aren't going to be covered. So this will, generally speaking, be a gain for behavioral health people, because everybody will be covered for behavioral health. Yeah, the reimbursements are not going to be as high as private health insurance, but private health insurance rates are usually pretty low. I know that there was a big stink a few years ago, and there was actually a successful lawsuit in New York State because the private health insurance rates were, what they said were community rates were ridiculously low. And it may have been the public employee plan. I talked to some people about this 10 years ago or so. Anyway, I looked and saw what the rates were, and they were higher than Beacon was offering for people in the UMass Group Insurance Commission. So I don't think that many people will be losing by not getting private health insurance rates. And they will be gaining substantially because people are able to afford coverage, since they will be, covered for behavioral health, which will be a gain for everybody.
Thanks, Jerry. We still have some questions in the queue, and I'd like to get to all of them. There's a question from Adam Cook. Are there overlaps between administrators at health insurance companies and other types of insurance companies? In other words, would those who lose jobs in the move from private to single payer find transferable knowledge and skills?
I'm sure some, and there are people who agents who sell health insurance, who also sell, automobile insurance, whatever. But I think generally they're not transferable skills. It would be, and even if they were, presumably these other divisions of the health insurer are already fully staffed. I mean, in a serious way, although it's kind of gross, I suggested in my book that we might consider just buying the health insurance companies. It's kind of gross to think about, oh, you guys are doing such bad things. I've also suggested in another context that we buy the goddamn fossil fuel companies just so we can close them down before we roast the planet. But this is comparable to compensation for slavery, buying, which Lincoln proposed as late as 1864. We'll just buy all the slaves. It'll be cheaper than fighting the war.
Let's not digress too much.
Right. Sorry. I'm wandering.
We should tell the audience that there's more to study regarding the impact on the workforce.
Mhm.
And
Yeah.
many of the transferable skills do belong to those in the insurance business who are nurses and doctors.
Oh, there's no question. Those people will be fully employed. There's no problem there. Doctors and nurses who are currently wasting their time and wasting their training, doing utilization review and other activities for the insurance industry will find plenty of opportunities to work in a constructive way, treating the currently uninsured and underinsured. And doctors who are now spending hours every day processing information for the health insurance industry will be able to apply those hours to treating their patients. Instead of these 12-minute or maybe 15-minute intervals, they'll be able to maybe spend 20 minutes. Wouldn't that be nice for everybody?
And sticking with the workforce questions, Henry Rose asks, many of us docs trained at elite urban institutions. If these institutions do less well, won't that hurt the supply of well-trained docs, already a problem in the Berkshires?
If the elite institutions like Mass General do less well, will they no longer take residents? I don't know. I think that it's reasonable to ask, why would they really do that much less well? Medicare rates are adequate. We're adding 10%. The American Hospital Association claimed Medicare rates are currently 9% below cost. I don't buy the number, but let's accept it. And we're raising their rates by 10%. We're adding Medicaid, improved Medicaid reimbursement. That helps them. We're taking some of the burden of administrative costs off them. If Medicare was such a bad deal, why does virtually every hospital in the country take Medicare? They may not love it, but they'll be able to treat patients and train residents perfectly well. And think about how much better your life will be as a doctor if you don't have to deal with the health insurance system. And how many doctors have left the profession because of burnout associated with having to process paper for the insurance industry, having to get, to quote my friend, some snot nose in Omaha who knows nothing about my patients, having to get that person to approve needed treatment, the treatment that you, after a decade of training, are qualified to prescribe. So all things considered, I don't think that we need to worry, but if we are worried, there's a simple solution. Mass care should pick up, and I know it's not in the bill, but it's something for us to think about going forward. Mass care should pick up the cost of medical training on condition that you stay in the Commonwealth for 4 years or something. Working in the Commonwealth is not burdensome for a doctor. especially if we did away with the health insurance industry. And then you wouldn't come out with $200,000 in debt, for your medical school tuition. I think that would be a good thing to do in general. But it's something that we could imagine funding in the bill.
And I'm getting ready to, we're getting ready to close at 8, but I wanted to just acknowledge there were questions in the chat that go to the strategy of winning the campaign more than to the economics of the bill. And some of this discussion has to continually come up as we work with the legislature and we work with the people in the grassroots. So I'm not asking you to answer these questions, but I thought I would acknowledge that there was a few that are, things to worry about. Candace, won't the elite hospitals do everything in their power to defeat this? Madeline, I don't understand how we can counter the power of the hospital industry, the drug industry, and the insurance company. Henry, what if the feds refuse to release Medicare funds to the trust? And we will be working with our hubs and the unions and the other organizations that are part of our coalition to solve these problems that definitely exist for Massachusetts and every state that wants to establish a single payer. And we're closely watching how California and New York are also navigating these same questions and working with their constituencies to win, because they've actually gotten majorities in their legislature, one house or the other. So with that, I'd like to turn the mic back to Sean. And I guess we had a few hand raised too.
Yeah, and we do currently have one. Thanks very much, John, for handling all those questions. We can go to Don, who's got a hand up right now.
Yes, it's obvious that everything that Gerald said today is an imperative for Massachusetts and really should be done. But I'm a Californian, so I would not benefit from a plan in Massachusetts. But one of my favorite economists did write a book, Medicare for All, old Gerald Friedman, for the entire nation. And we really need to do this for the entire nation. But the problem is we've been talking about it for a few decades and we haven't gotten there yet, anywhere near there. And that's what we have to do now. We have to enact the program. And Gerald has provided us with a tremendous amount of data that does make it an imperative for the entire nation. And we have to go to Congress now, and we have to get the program moving. I see no other option. So isn't that right, Jerry?
Absolutely. Do we have time for my joke? It's actually Wilbur Mills's joke. I think Don might have heard this or know this already. Wilbur Mills, chair of the House Ways and Means Committee for many years, said that when Harry Truman died, he went to heaven and St. Peter greeted him and said, "Oh, Mr. President, the big guy wants to see you." And Harry Truman went before God, and in all her majesty, she spoke down to him and said, "Mr. President, you were such a good man. I want to give you a gift. You may ask me one question." So Truman asked, "Will we get health insurance, national health insurance in the United States?" And God said, "Oh, of course we will. Just not in my lifetime." I hope we get it in my lifetime.
We
Thanks.
certainly do all hope that. Thanks very much, Jerry. I just wanted to make sure we do have a little more time. So if people have other questions, we could take a couple more. But I just wanted to thank Jerry, for the great presentation tonight and for all of your work over the years on this. Thanks to John for fielding questions. Thanks to Stephanie at MassCare. Also, just people, she put it in the chat as well, but MassCare is hosting a lobby day at the State House in Boston next Thursday, May 4th, a week from tomorrow. And so you can go to the MassCare site at the link there and find out more details about how to participate.